before we begin, I want to thank Sandoz and Sanofi for their sponsorships, for letting us do this program. And let's take it away, Dr. Boster.
Howdy. Hello, everyone. Happy Tuesday evening on this somewhat cold Ohio winter day. Thank you all for joining me. Thank you, MS Views and News, for creating this opportunity. It's really awesome to get a chance to connect with you guys. I've been asked tonight to speak about the future of multiple sclerosis, highlighting sort of what's coming down the pike. And so I wanted to spend a few minutes and talk about the near-term future in MS. A couple topics that are very, very top of mind. One is the utilization of artificial intelligence, AI, which is already starting to be seen in the MS space. I also wanted to talk about the future of MS diagnostics and prognostic tools and some biomarkers, which are starting to become prime time in the MS space. And then lastly, I wanted to touch on a couple of the future therapies, which could literally revolutionize the way that we manage the disease. So the topic again is talking about the near-term future of multiple sclerosis, and I hope that you find it interesting. I'll be happy to answer questions in the second half of this discussion after I conclude the didactic. So AI, artificial intelligence, is sort of a revolution in and of itself. I have a self-driving car. I don't steer or hit the brakes or the gas. It does it for me. I also don't navigate any longer. It navigates for me. And I think when I think back to being a kid and thinking about AI, I thought that it would create robots that would do manual labor, and I was wrong. Where we're seeing AI more and more is in white-collar spaces, including in the setting of medicine. And so presently, I use AI in my clinical practice in three separate ways. One way that we use AI right now is in assistance in reading MRI scans. So when we're trying to assess if someone is living their best life despite having MS, one of the many ways that we do that is by looking at the structural biomarker, the MRI. And it's my preference in the Boster Center for MS that we get an MRI of your brain about once a year, and I get an MRI of the cervical spine about every other year. And when I'm getting the brain MRI, I'm looking at several things. I'm looking at the white spots, and I'm looking to see if there's any new or enlarged white spots. I'm looking at the dark spots, the T1 hypointensities or black holes, again, to see if there's new ones. I'm looking at the contrast enhancing lesions when we give the contrast dye injection to see if any of those spots light up to tell me that they're newly active. And I'm a big fan of looking at brain volume and changes in the volume of the brain, both the whole brain and then a structure called the thalamus. Now, in the past, we ballparked MRI volume, but with really poor man's measurements. We would measure certain structures literally with a ruler, and we would look across years, and that's a really, sort of arcane way of doing it. Now I leverage an AI software called NeuroQuant. So NeuroQuant is a proprietary FDA-approved software. It's one of several that are approved, but that's the one that I have the most experience with. And when the MRI is obtained, certain files are sent to the NeuroQuant computer, which I think is in California, and it very quickly processes the brain volume, which is really kind of highfalutin. It has to segment out the different parts of the brain in the computer and then measure their volumes and then spits back numbers. Not only does it spit back numbers about the volume, but it compares it to healthy controls for age-matched controls. So if you're a 49-year-old fella, it'll show you a graph where your brain volume is compared to a range of people your age. None of them have MS. And this is a very, very powerful way of assessing an aspect of MS which is otherwise missed. And it's completely generated through AI. There's another software that I choose not to use, but it's commercially available, again, by the same company, and it's called LesionQuant. And LesionQuant finds the MS lesions and compares them across time to see if they've gotten bigger. And so I think increasingly we will see AI used in neuroradiology, as it's already starting to be used in the setting of MS. I use it every day. I used it 10 times today. looking at brain volume with MRIs with patients. So that's one area where I see AI really helping. A second area where I personally use AI, some of you know that I have a YouTube channel, and when I'm trying to come up with hot topics for MS, I will sometimes I'll have a conversation with the AI. What are topics that people are looking into? And it'll help spit out topics. Or if I'm trying to summarize a video that I've made, I can put my video into AI and it'll spit out like a summary, which I can use as a video description. I also have started to use AI to help me generate thumbnails. So I'm not an artist. And so when I'm making a YouTube video and I'm making a thumbnail, I will leverage AI to help me design it. A third way that I use AI in my clinical practice is related to insurance correspondence. So when we are going to start a person with MS on a disease-modifying therapy or on a symptomatic medicine, many of them require a prior authorization from the insurance company. In other words, the insurance company has to be asked if they'll pay for it, and the person has to meet certain criterions that they make up before they'll approve its use. And sometimes they deny them. And so they provide a denial letter, and then we have an opportunity to rebuttal that letter. And so we will write a rebuttal to the denial letter. And traditionally, that's something that my nurses and I craft together, and we'll explain the clinical history of the patient and the reasons why this drug is the best fit for that patient. We'll explain the reasons why other drugs have either not worked well for that patient or are not appropriate. We now can use some really powerful AI software to help guide us in that writing. And some of the benefits of using AI to do that is the AI will go into the medical literature and find citations, articles to support what we're saying. And so already, 2025, the very beginning of the year, I'm using AI in my clinical practice in those three ways. And I think that it enhances my practice. Now, do I think that soon I'm going to be out of a job as a neuroimmunologist and some computer will do it? I don't think so. But in the same way that my car drives itself to work, I think that certain aspects of MS care, which can be automated, will benefit from AI technology. Now I'm going to shift topics, staying on the theme of the future of MS, and I wanted to talk about biomarkers. So biomarkers are tests that give us insight into how the human being is doing, in addition to talking to the human being or examining the human being. And right now, the very best biomarker that's available to diagnose MS and to assess treatment response and prognosis is the MRI. So the MRI is a structural picture, and it's the best biomarker that we have. But the MRI is also invasive. You have to cram your head inside of a scary tube. And if you're claustrophobic like me, that's not a small matter. And it's very, very expensive. And it's also not ubiquitously available. Not everybody has access, for example, to high field imaging. And so it would be awesome sauce if there was a simple or a more simple biomarker. And there's one which has been developed over the last several years, and I now view it as being close to prime time. And it's something that I've already started to incorporate in my clinical practice. And it's a blood test. And so there's a company called Octave, and I don't have a financial relationship with Octave. I just think their lab test is really good. So I'm delighted to talk about it. It's a blood test which looks at 18 different blood markers. And this company Octave has done a lot of research, and they've proven and published papers to prove that the score that's generated by collecting all of these 18 biomarkers into one measure, which they call the disease activity measure, is predictive of disease activity. It correlates with new MRI lesions or enhancing MRI lesions or new attacks. And so we can draw blood on a patient in clinic, and we can send off this Octave blood test. And within a week or so, we get back a report, and it gives us the DA number, the disease activity number. And it batches it low, medium, high. And if it's high, there's a very concerning risk for disease activity. If it's medium, a little bit less so. And if it's low, that's very reassuring. Now, it's not the end-all be-all of MS diagnostics, but it really enhances my understanding of what's going on. It's not also paid for yet by insurance companies, which is a real bummer. And patients that elect to do it have to pay several $100s, which is simply not in budget for some families. If in the future, this is a test which is approved by insurance companies to be ordered, I will probably get it every quarter, because I think having that measure every 3 months would really give me a tremendous amount of insight into how the person's doing. And maybe it might ultimately lead to me ordering MRIs less often. So that is sort of the future now. And I think where tests like the Octave DA test are going is becoming mainstream, becoming approved by insurance companies, becoming commercially available, so that their access is really, really ubiquitous for all patients. The last topic that I was hopeful to briefly touch on as it relates to the future of multiple sclerosis is therapeutics and sort of where we're going with therapeutics. And I'd like to highlight maybe 2 or 3 future therapies. The first one that I'd like to talk about is, I would say, a 3rd generation attempt at manipulating B cells. So presently, some of the very best medicines that we have available to treat MS work by depleting B cells, B cell depleters. So these are things like rituximab, ocrelizumab. We have other drugs like Kesimpta and Briumvi that have joined this market space. And these are really good drugs to decrease B cells. And when you decrease a B cell, you really slow down the MS disease quite considerably. The problem with B cell depleters is that by suppressing B cells, we increase the risk of infection. And it would be really awesome if we could manipulate or dampen B cells without murder, without killing the B cells. And so there's a set of drugs that are currently being studied, the BTK inhibitors. And I've talked about the BTK inhibitors quite a bit on my YouTube channel and here on MS Visa News. And there's a lot of data being generated about BTK inhibitors. It looks like the BTK inhibitors are not hitting the mark with relapsing MS, but they do appear, at least so far, to show some promise in progressive disease. Specifically, there was one BTK inhibitor called tolebrutinib, which was studied in a trial called the Hercules trial, and I'm very proud to have participated in that trial. And in the Hercules trial, it was able to slow down non-relapsing secondary progressive MS by 29%. These BTK inhibitors are still being tested, and there's a trial that I'm involved in called the Perseus trial, which is looking at primary progressive MS. So fingers are crossed that the Perseus trial is going to have a positive result in the same way that the SPMS trial did with Hercules. There's another set of drugs, which I sort of think of as like the next generation after BTK inhibitors, that are very, very exciting. And they're called anti-CD40 ligands. Now, I didn't make up any of these weird terms, but the CD40 ligand is an apparatus that the B cell uses to communicate with the T cell. So pretend that my fist is a B cell and this fist is a T cell. The way that the B cell and the T cell talk literally is by touching. And they have these appendages like arms, and they touch each other. And that's the way that they literally physically make contact to communicate. The arm is called the CD40 ligand. That's what the sticky outy part is called, the CD40 ligand. And so these new drugs, which are anti-CD40 ligands, are kind of like putting a condom on the arm so that it can't physically touch the T cell. And one of my patients suggested that it was like a condom, and I thought that was an awesome visual. And so we're studying these anti-CD40 ligands. There's a drug called frexilizumab. And right now at the Boster Center for MS, we're doing clinical trials with frexilizumab, this anti-CD40 ligand, both in relapsing MS and in secondary progressive MS. Now, again, one of the advantages of BTK inhibitors and one of the advantages of these anti-CD40 ligands is they don't murder B cells. They just make them not able to communicate. And so I think part of the future of MS therapeutics is developing therapies that are highly effective like the B cell depleters, but without the same increased risk of immunosuppression and risk of infection. Now, moving a little farther into the future, I'm very excited to talk about a sort of a potential revolution in therapy, and this is CAR T-cell therapy. So CAR T-cell therapy, or sometimes abbreviated CAR T therapy, is really exciting and very, very different from almost anything else that we've brought to the table to treat MS. So I'd like to explain it a little bit. CAR T-cell therapy stands for chimeric antigen receptor T-cell therapy. So chimera, or the chimera, the chimera is a Greek mythologic beast that was made up of different animal parts. So it had like the head of a lion and the wings of an eagle and the tail of a donkey or something. It was a composite animal of a lot of different parts. And so chimeric antigen receptors are these T cells which have been genetically modified to have a different purpose. So what's done is really cool scientifically. So you take a person and you take out some of their T cells in the laboratory and you genetically modify them so that they have a new receptor that binds to something bad. And then you take this CAR T cell and you stick it back in the human, and then it goes and does its job. And so CAR T cells have been developed successfully to treat lymphoma and leukemia, which are blood cancers. And there's been a couple of medically refractory B-cell lymphomas, which did not respond to traditional chemo, which were cured with CAR T-cell therapy. So in these patients with medically refractory leukemia or lymphoma, they took out their T cells, re-engineered them to identify the cancer as a bad guy, stuck them back in the human's body, and the T cell bound to the cancer and called in their immune system to kill it, and it worked. And so we're starting to develop clinical trials to study CAR T-cell therapy in MS, which is very, very exciting. Now, CAR T-cell therapy has a couple things about it which are hurdles to overcome. One is that it's very, very specific. It only works for that individual. So you're building this entire very specialized genetically engineered treatment for one person, which is great for that one person, but it's also extremely expensive. And so we're going to have to figure out ways of producing this more quickly, more easily, and with less expense. Also, when you give CAR T-cell therapy, there are some risks of what's called a cytokine storm. And so there has to be some very significant precautions when administering CAR T-cell therapy so that we don't cause damage from a cytokine storm. So I will stop the didactic at this part. I was delighted to talk about sort of what's coming in the future, and the future is now. Already, we're starting to see the earliest applications of AI, not just in my program planning for my YouTube channel, not just in reading MRIs, but even in corresponding with insurance companies with writing scientific rebuttals. We're seeing new biomarkers start to enter into the field of MS, going beyond the traditional MRI. And there are blood biomarkers like the Octave disease activity test, which I think are starting increasingly to become prime time. And the future of MS therapeutics is brighter than it's ever been. We're taking the fantastic therapies like B-cell depleters and coming up with new therapies which don't have the same risk profile. Things like the BTK inhibitors, things like the anti-CD40 ligands. And lastly, there are new therapies on the horizon that are really quite revolutionary, like CAR T-cell therapy. So thank you for letting me kick things off with a little taste of the future. I'll kick this back to our host, Stuart, with MS Views and News.
All right, thank you again. And I do see that we have a lot more people online than even when we first began. And we do have questions online, and we do have questions that I have taken down from people that have written to us previously and wanting to know further about things. One of which, before I get to any of the online questions, and everybody, listen to me carefully. I do not know what you're thinking if you have a question for Dr. Boster. So if you have a question for Dr. Boster, do not wait for somebody else to ask that question. Type it, all right? Let's get the questions in so we can get your questions answered. Thank you. All right. Recently noted online from Dr. Brandon Bieber, I think, on Twitter or X, whatever you want to call it, there was a statement said that in MS, using stronger treatments, Tysabri, Novantrone, Rituximab, Ocrevus, Gilenya, early use is linked to a 3.7-year delay in reaching moderate disability. But I thought that so many others like yourself have said that, you know, the use of this will hopefully prevent you from getting more disabled altogether, not just a just under 4-year advancement of disability. So how do you answer that?
So there's a larger conversation which I want to help bring to light, and then we'll get into the specifics. Traditionally, and in my mind, mistakenly, the way that MS therapeutics have been used is in a escalation model. And so a lot of old school MS neurologists still adhere to this false idea that the best way to approach treating MS is to start with low efficacy drugs, meaning low numbers of success in slowing the disease, which they think to be very safe. And if they put you on a low efficacy drug and you do great, then they're a great doctor and you're a great patient, hooray. And if you don't do great, well, don't worry, that's okay. If things don't work out, then they will escalate to a drug which is, at least in groups, more effective, but might have a, quote, less attractive side effect profile. So they'll escalate. And then they'll see how things go on that next drug. And if that goes great, well, then they're a good doctor and you're a good patient, hooray. And if that doesn't go well, don't worry about it, then they'll escalate even further. And that model is terribly flawed because damage done can't be given back. You can't regain brain damage lost. And what we've seen time and time again is the earliest application of the most effective medicine off the get-go is the best way of making the disease slow down. And I am delighted that we're now seeing increasingly studies supporting that belief. So what Dr. Bieber was commenting on was a French study which looked at the use of either the first-line injectable medicines like the interferons and Copaxone, things like that, versus starting high efficacy. And what they found was it delayed the onset of disability, proving that the point that I just made. I would not recommend getting into the weeds because the take home from that study is earlier use of high efficacy is better, right? So I don't think the point is, oh no, it only slows things down this much. It's proving the philosophical point that the earliest application of high efficacy medicines is going to fare better for the human being long term. And so that's really the broader picture. And so I'm very, very excited that we're starting to see more and more clinical evidence supporting that belief. And Dr. Bieber does a great job helping educate and empower folks. And I was really glad that he put that out there.
Great, awesome. Thank you for that. And going further though, does MS treatment matter? 9 years later, difference in brain volume loss, what is there? I mean, what can you talk about brain volume loss over the years, even with people using, say, the same type of treatment?
So when we're trying to assess how someone's doing with their MS, to me, the most important thing is their life experience, is the litmus test of life. I think that's the most important. Are they having attacks, God forbid? Are they failing the litmus test of life, having trouble doing their activities of daily living, working, spending time with loved ones, etc.? And then we look at some secondary measures. For example, we look at the examination. I sometimes joke, the MS Olympics. And is the exam getting worse? And we have the old school traditional exam where we beat you with a hammer, and we have sort of the newer measures like the timed 25-foot walk, et cetera, et cetera. And those are functional measures of how the person's doing and what their exam looks like. Thirdly, going back to the lecture that we just discussed, that I gave, we can use a biomarker, the MRI. And in the old school days, we only looked at the white spots and the enhancing spots. Now we've become more savvy. We look at the dark spots, the T1 hypointensities, and we look at brain volume, so the size of the brain and how quickly it's shrinking. All brains after the age of 18 shrink on purpose. All right, they're supposed to shrink about 0.2% a year, 0.2% a year. In the setting of untreated MS, that can be sometimes up to 10 times faster, all right, which is very scary. And that correlates with significant problems with long-term disability and with cognitive dysfunction, bad stuff. Some of the MS medicines are really bad at slowing brain volume loss. Some of the current FDA-approved therapies are just not very good at slowing brain volume loss. Some of the therapies are really good at slowing brain volume loss. So when you're picking an MS therapy, it's not just relevant to think about, does it decrease relapses? And it should decrease relapses. It's not relevant just to say, does it stop new spots? It's also relevant to ask, how good is it at slowing brain volume loss? And as I shared earlier in my didactic, I measure that every year in my patients, and it's an actionable measure, because if the brain is shrinking too quickly, I think that's not okay. That's a great question.
Great, thank you for that. Next, we have a person that, in response to what you're talking about, if we're stable for years on one of the original DMTs, would you still suggest switching to a high efficacy medication?
So that's a very fair question. There are people who are super responders to any medicine, and we're not smart enough ahead of time to know who's going to be a super responder and who isn't. And if you are, in fact, a super responder to one of the original medicines, that's great. But I want to make doubly sure that you're really, really stable. So in other words, just not having attacks doesn't qualify in Aaron's book as being stable. It's not enough just to say I'm not having attacks. In order for me to consider things stable, no attacks, no new spots on MRI, normal rates of brain volume loss, exams not getting worse, okay? And sometimes we need to get a little deeper, and I'll even do like formal neuropsychometric testing to make sure that I'm not seeing a loss in cognition. So I have patients, and when I say I have patients, I have like 2 patients out of like maybe 1,500 in my practice who are on first-line therapies and they're stable, right? And those 2 patients out of 1,500, I don't change their drug. But truly, I have bent over backwards to assess them deeply to make sure that I'm not missing something. So if you truly are crushing it on any given drug and we're not missing things, then no, I wouldn't necessarily change you. But it would take a very, very low threshold for me to want to escalate to something that, at least in groups, works better.
Okay, awesome. Thank you for that. Next, how can you tell the difference between brain volume shrinkage and associated with normal aging? Person writes, I'm 59, versus brain volume loss or atrophy with regards to MS.
So one of the ways that we do that is we have what's called normative data. So normal data, where hundreds of thousands of people that don't have any neurological problems have the size of their brain measured. And we can create a graph which looks like a kid's growth chart, right? And it gives us the average brain size of a 59-year-old, and then it gives us the standard deviations. So we can say 66% of all 59-year-olds are going to have a brain within this size, and 99% are going to be within this size. And then we can put your brain volume on that graph. And we can see, is your brain bigger than the average bear for someone your age? Is it smaller than the average bear, etc.? And so by comparing it to normative data, we can really answer that question. This is very similar to what we do with kids' growth charts. So when your kid was going to the pediatrician, they would measure her height, and then they would put a dot on a graph, and you could see where her height was for her age compared to girls her age. And it would give you a percentile. So if she was really tall, she might be in the 90th percentile, meaning that her height is taller than 90% of people her age. We can do the exact same assessment with someone's brain volume.
Okay. Next one, in regards to the DMT meds, how can you treat MS? How can you treat patients who have tried several drugs where the side effects were so unbearable to continue with the medication? What would be the next steps to manage their MS?
So I've been doing MS neurology since my early 20s when I was in training, and I turned 50 in 2 days. So I've got several years of experience managing multiple sclerosis. I have failed 0 times finding something someone can take. So I challenge what you're saying. There are 28 FDA-approved therapies, different formulations of FDA-approved therapies. Some of those are different flavors of the same therapy at different doses. There are a host of drugs which are not FDA-approved, but we still use them, like IVIG and cyclophosphamide, Cytoxan. And there are a host of drugs which are currently being studied in research. And so I bet you $1 that you haven't tried everything. And we would simply need to look very carefully at what did you try, what was wrong with it, like what didn't go well. Is there A, way of giving it to you differently, or B, is there a different drug that we haven't tried yet? And I'll give you a couple examples. So gluteramine acetate, Copaxone, is an injection that you take under the skin, and it can cause a welt. And so one of the tricks that I learned when I was a younger man was you take the shot in the shower with you, and you wash your body with warm water and soap, and your body's clean and it's warm, and the shot is now room temperature, and you inject yourself in the shower, and it decreases the risk of welt considerably. It makes it much more tolerable. So that's a quick, not silly, but it's a quick example of how you can give a drug slightly differently to make it more tolerable. So I would challenge you that we should go back to the blackboard or the whiteboard and write down all the things you've been on and why, and really game out, is there something we could do different, or is there something that we haven't tried yet?
Great. Next, let's go to, you just brought it up, gluteramine acetate, Copaxone. Recent studies are showing that it's causing heart problems. Recent studies are showing that you can develop possibly cancer. What have you heard about this, and what can you tell the community?
So I was trained by a great MS neurologist named Omar Azar Khan. So Dr. Khan, who has passed away now, was a huge advocate of gluteramine acetate Copaxone. He actually developed the 3 times a week formulation of Copaxone. And the reason I'm bringing that up is I grew up giving people Copaxone. I used a lot of gluteramine acetate in my practice. I haven't prescribed gluteramine acetate in 15, 20 years, not because of side effects and concern, as you're seeing in the press these days, but because there are drugs that are categorically better. So I'm not trying to not answer the question, but my question in return is, why bother using something that doesn't work very well? For example, there are telephones, cellular phones, that were made in 1995, the same year that Copaxone came out. And I bet you that not a single person that ever listens to this live stream is using one of those phones. Those phones work. And you could argue that they're not as safe, they don't have the same security technology, but that's not why we don't use them. We don't use them because these phones are like freaking supercomputers that are far superior to the phones that were made back in 95. So I would rather use a modern phone, and I would rather use a modern therapy.
Great answer. Great answer. Next, on reference to the anti-CD40 condom that you were talking about, is there side effects from them not talking to each other or other complications?
So if a doctor ever tells you that there isn't a side effect, that doctor's lying, because everything has a side effect. You can actually overdose on water if you take enough of it. And there are side effects that you can see with anti-CD40 ligands. But the point that I was trying to make is they're a lot less as it relates to immunosuppression. They're a lot less as it relates to risk of infection compared to the current B-cell depleters. And so I won't get into a laundry list of those side effects because my intention is not to game out the details of the drugs. These are under investigation. It's to simply share with you where the field is going. Now, one of the reasons we do phase 3 clinical trials is to continue to characterize not just the good, but the bad and the ugly. And so part of the reason that we do these in-depth clinical trials is to characterize and describe these side effect profiles of these medicines in people impacted by MS.
Okay, next, thank you. I'm not going to say thank you after each one, all right? Just so everybody knows, I'm not being rude, but we've got a lot of questions to go through.
We're doing good.
Next. Hi, I'm an 82-year-old female diagnosed in 2005. Last August, I was hospitalized with severe 4 UTIs, not 3, but 4. My neurologist changed my DMT from Aubagio to the generic of Copaxone. Would that have been your choice? If yes, why? If no, what would your choice be, and what? Thank you.
So thank you for that question. Bluntly, I don't have enough information to properly answer. What I'm
Good
hearing is the person had a severe urinary tract infection, so severe that they were hospitalized. And that's nothing to sneeze at. That's a very big deal. Now, my assumption is that the neurologist was concerned that the Aubagio could have increased the risk of the urinary tract infection, all right? And that's an assumption because I don't have that information. What I can say to you is that of all the drugs that are approved for MS, the drug with the least side effects and the lowest risk of infection is Copaxone. So if you have a situation where someone has a severe concern on the table and you want to treat their MS, you may reach for a Copaxone. So back in the day, we would, if someone had MS and HIV, Copaxone was the answer. MS and hepatitis, Copaxone was the answer. MS and pregnancy, Copaxone was the answer. And so maybe that neurologist was trying to game out, how do I treat your MS with the least risk possible of hurting you? But I don't have enough information to weigh in on the specifics.
Thank you. So for everybody else, please know that if you have questions that relate only to you, you can't ask them because Dr. Boster doesn't know you to be able to answer those questions. Let's get on to something else. Let's talk about the repurposing licensed drugs with activity against Epstein-Barr virus for treatment of multiple sclerosis. This is something that I believe you wrote about. Let's hear more about it, please.
So there is an ongoing discussion about what causes MS. So what's the cause of multiple sclerosis? And it's been clarified in the last several years that one of the hypotheses that Epstein-Barr virus plays a role in MS is probably true. So many of us now have agreed and accept the idea that one of the requisite requirements to develop MS involves being exposed to something like Epstein-Barr virus. And so let me kind of explain to you the party line, how we think that might happen. So not everyone who gets Epstein-Barr gets MS, of course. So that's not what I'm saying. But let me back up 2 steps. There is a genetic predisposition among certain populations to develop autoimmunity, right? And groups of people share similar genes, including genes for the immune system. And so, for example, a lot of folks that hail from like Western or Northern Europe who share the same genes for hair color and skin color and things like that, and they also share genes for their immune system, they may be at slight increased risk of developing autoimmunity. Now, that's not enough to give you MS. Otherwise, like every pasty white kid in the Midwest might, have MS, and that's not the case. We then think that there are environmental risk factors which can increase or decrease the risk. And some of these risks have been clarified. For example, morbid obesity doubles your risk. For example, smoking doubles your risk. For example, having mononucleosis increases your risk times 37. So not 2 times, but 37 times higher. And that's insanely higher. And so we believe that what happens is when you are exposed to mono, EBV, mononucleosis, Epstein-Barr, the kissing flu, glandular fever, that's all the same disease. Your immune system builds an arsenal to beat up mono, and you keep that immune response the rest of your life. But by accident, the immune response that can identify mono, by accident also identifies myelin as mono because they look similar molecularly. And so now when the immune system does its tour of duty floating around the bloodstream looking for mono, if it sees the noggin or the spinal cord, it thinks it's looking at mono and it attacks it. And so that looks like it's probably true. So if we were able to prevent mono, or if we were able to treat mono, maybe it would help slow down or prevent MS. So one of my dreams is to administer a generation of people being born a vaccine against mono. So this probably wouldn't be readily accepted in the United States because for some horrible reason, Americans are resistant to life-saving vaccines, much to my chagrin. So maybe we'll do this in a country which is more advanced in its understanding of medicine, like in Finland, okay? So we take like all the Finns and we immunize all of their children for like 10-year period against mono. I think we wouldn't see MS in that generation of people. Now, what we're talking about here is there are drugs which have been developed to try to treat mono, and could we use those medicines to try to treat MS? And that's a question mark, but it's a really exciting question mark, and so more to come.
Thank you. So I had mono when I was 16 or 17, and then I got mono again, supposedly when I was 17 or 18. I don't remember, but my MS doctors down here say that that second bout of mono was actually probably my first relapse to MS.
Could be. You know, when we looked at this big epidemiologic study, Stuart, where they looked at 10 million Americans, this was done in 2019, and they were all in the military. And what they found was 95% of them had been exposed to mono. So mono is ubiquitous, like almost everybody gets mono, 95%. Of the 10 million GIs that were looked at, 800 and change had MS in that cohort. They had multiple sclerosis. 99.9% of those patients had mono. And when you're dealing with numbers that large, that is highly statistically significant. Now, there is someone listening right now who is saying, yeah, but I have MS and I never had mono. And two comments. Comment number one is you don't have to have manifested an infection like a fever and being sick and missing school for a month to have been exposed to mono. And many people, they got mono and they just had like a little sniffle and they cleared it. And if you test their blood, they've been exposed to mono. Also, I'm not saying that that's the only option. Maybe there's another virus that we haven't discovered yet, which also leads to this. I'm simply saying that this evidence is overwhelming that for most people, this probably is related to how they developed MS.
Great, thank you. So speaking about vaccines that you were talking about a few moments ago, a person wants to know about vaccines and multiple sclerosis. Should they get a COVID vaccine? Should they not? I mean, what is your opinion? Is this something that they should be doing?
They 100% should get a vaccine for COVID. So COVID can kill you. COVID is not like the sniffles. COVID is not the flu. And I've lost several patients to COVID. And the vaccines for COVID are life-saving. So I absolutely recommend that people get vaccinated for COVID. I am vaccinated for COVID. I am boosted for COVID. I'm not going to miss a COVID shot. And I don't think you should either.
Thank you. Next, MS and pain. Let's talk about it for just 3 minutes if you can. We've still got like 10 other questions at least.
Absolutely. So Stuart and I have had many, many conversations about MS and pain. And over 70% of people impacted by MS suffer from chronic pain, which is pain that lasts for longer than 3 months. Actually, right now on my YouTube channel, I'm launching several videos on a series on pain. I have a four video series looking at MS pain. The short and the long of it is MS causes several different kinds of pain. Some of them are very unique to MS. People impacted by MS are 14 times more likely to develop trigeminal neuralgia, some of the worst pain that a human being can experience. Optic neuritis hurts like mother you know what. Some people develop Lhermitte's phenomenon when they bend their neck down, they have electricity shooting down their back. We have the MS hug where they feel like they're in a vice and being crushed. You can have neuropathic pain on any part of your body where, I'll just use a limb as an example, where it can feel like it's being burned or it's being shocked or it's being frozen. Spasticity is very, very common in MS, and spasms and cramps and Charlie horses hurt like the dickens. They can drop a man. MS can make you walk in an abnormal manner, which puts unnecessary pressure on the joints and the soft tissue, which can cause orthopedic and mechanical pain. So there's actually many other examples that I could give. Migraines are very common in MS. Occipital neuralgia is very common in MS. And chronic pain can destroy your quality of life. And so chronic pain, fortunately, can be treated. And so I spend a lot of energy, my nurse practitioners spend a lot of energy at the Boster Center treating chronic pain in MS. And there are a host of ways that we do that. I'll finish the response by saying, if you have chronic pain, do not accept it go to your neurologist, go to your pain specialist, say, I have pain and I need it to get better. And if the neurologist isn't comfortable, that's okay. Say, I just need you to refer me to an expert that can help me manage this pain because it can be treated.
Thank you. So you know me, and you know that I've been living with pain for 56 years, okay, and I deal with it, all right, best I can because I don't like the drugs that go along with it. So we just pioneer and go forward, that's all. Next thing, Asians and MS. Why is multiple sclerosis so rare in the Asian community?
So my friend, Dr. Brandon Bieber, just did a beautiful YouTube video answering that exact question. So I'm not going to steal his thunder. Go to Brandon Bieber's channel and check out his video on why Asians don't get MS. That was the title of the video. The short answer is genetic predisposition, which doesn't mean Asians don't get MS. It just means they get it a lot less often. There are some neurologic conditions which are cousins of MS, which we can see more often in Asian populations, like neuromyelitis optica spectrum disorder.
Okay, thank you. Next, we have, gosh, I got to go back and find this one. All right, what if you have PPMS and you're on Ocrevus, but your symptoms are still getting worse?
So, three comments. The first comment is when we did the Oratorio trial studying PPMS and studying Ocrevus, over a 2-year period, we were able to slow down the worsening by 24%. So about 12% each year for 2 years, which is awesome, but that's not very big. And so at the end of the 2-year trial, both the treated arm and the placebo arm got worse, but the treated arm got 24% less worse. So those are the expectations of the trial. So this is not a cure, and we need to do better. My second comment is we are studying drugs like tolebrutinib, BTK inhibitors, like the Perseus trial that I mentioned, and we are very, very hopeful and encouraged that we think these drugs should help improve PPMS. That remains to be seen. My third comment is I think that there's a lot of ground to be gained looking at managing symptoms. And I'll give you a quick example. A lot of people with PPMS have weak legs, but they also have spastic legs. And if your leg doesn't bend very well, it's real hard to walk normally. And if your spasticity gets worse, you walk worse. Treating the spasticity doesn't slow down the MS, but it makes you walk better again. And so paying attention to symptoms and improving symptoms can have a direct impact on your quality of life, not just like you feel better, but like you do better. So that was a great question. Thank you for asking it.
Thank you. Next person asks, what can you do? What is recommended for GAIT, G-A-I-T therapy for MS?
So it really depends on what gait problem you have. Let me talk about foot drop because that's a common problem. Right? There's a lot of different problems like gait problem. I mean, there's probably 60, 70 different gait problems in MS, but foot drop might be amongst the most common. So one way that we can improve foot drop is with physical therapy. I just interviewed Dr. Gretchen Howley, who is a brilliant physical therapist, and she and I had a long discussion about exercises to improve foot drop. And so when I put that video out, then you can see these exercises. I was going to demonstrate, but I can't do it justice. So if you have foot drop, physical therapy is one thing you can do. Another thing you can do is you can get an ankle foot orthosis, which is a device which is like an L shape that goes in your shoe and up the back of your leg to pull your foot up, and it allows you to clear the ground so the turf monster doesn't grab your foot. There's also cheapo devices that you can buy on Amazon called a foot flexor, which is literally just a band that goes from your shoelaces and straps onto your ankle. It's like 20 bucks, 30 bucks. And so that can help with foot drop. There are electrical stimulation devices like the BioNess or the Walk Aid, which can electrically stimulate the muscles in the front of your lower leg to pop your leg up. And there's even really exciting things like the Psionic Neural Sleeve, which is a neoprene sleeve that goes up your whole leg that doesn't just help foot drop, but it helps the rest of your leg move. So there are a host of things that can be done. The best way to address foot drop, or if I broaden the discussion to gait problems in MS, is to see a neurophysical therapist. So there are traditional physical therapists who are very bright men and women, and a lot of them deal with like knee injuries and like sports recovery and important things like that, but they don't have extended education, excuse me, I couldn't say that word, in neurological problems. And so there's a smaller group of physical therapists that go back to school for several more years, and they become wizards in neurophysical therapy. And you want to see a neurophysical therapist to help game out how to make your gait better.
Thank you. Then on top of that, we need neuro-orthopedists.
Yes. Yeah.
Okay. All right. Let's go to the top of the list and get in some of the people that started this whole conversation. Can you give any information regarding the histamine response on MCAS and its impact on MS?
No.
Okay. Me neither. How would you treat claw hand?
So I'm assuming that claw hand is talking about when you have spasticity and your fingers are flexed like this, right? So when you have spasticity, certain muscles are overpowering others. So if we use my hand, there are muscles of flexion which pull my fingers together, and there are muscles of extension which open my hand up. And when you have spasticity of the hand, typically you can get the thumb stuck like this, you can get the fingers stuck like this, right, like a fist, but sometimes you have like a claw, right, because your fingers are curled in like that. So one of the ways to manage claw hand is to work with a physical therapist or an occupational therapist in stretching exercises. A second way is to get what are called splints or dynamic splints, where they put your hand in a device, and slowly over time, they can open the device up, or they can refit you with serial splints to open your hand, to stretch it out. Another thing that you can do is you can use Botox. So Botox is very popular for like cosmetic purposes, like to remove wrinkles, which is not what I'm talking about. Botox is very, very powerful at poisoning muscles. And so if these muscles that curl your fingers in are more powerful than the muscles that bring your hand open, you can poison these muscles. And what's interesting is these muscles connect down here. So we're not injecting you here, we're injecting you here to pull, and we, by poisoning them 5%, it allows these muscles to open up your hand, and we can find balance. So there's a lot of different things that can be done to help with claw hand.
Thank you. Isn't Botox also used in the leg muscles these days, or the legs for spasticity?
Yes. So we can use Botox. We use Botox at the Boster Center really for two purposes. We use it a lot to treat migraine, and we use it a lot to treat spasticity of the leg and of the arm. And so we'll inject the leg in the hamstring muscle in the back, the quadricep in the front, the muscles that pull your legs in, the muscles that turn your feet or claw your toes. We use it in the arm for, if you have an arm that's kind of flexed like this, we'll Botox here to relax it, here to relax it, here to open it up. And so Botox is a really effective therapy for focal spasticity, and it can last upwards of 3 months. And so you come in, you get injected, and then for the next 3 months, you're good in the hood. And so patients will come back once every quarter to get new Botox.
Great, thank you. Person writes, wasn't there some relevant information already in the standard blood tests that were indicating a possible upcoming flare?
No. So there's discussion about neurofilament light chain, which is still new, but the Octave test includes neurofilament light chain and then 17 other markers. And there's a really cool paper that looked at all of the Octave test compared to neurofilament light chain by itself, and Octave was better at predicting outcome. But aside from these tests, there's nothing that's prime time. I mean, there's other tests which are blood tests which are used in research, but they're not prime time, they're not commercially available.
Even with the Octave test, though, are there no markers yet to indicate actual person that will worsen in the next year or versus a person that won't worsen? I'm only asking because I've heard from some doctors that they're actually seeing high numbers showing that a person is going to get worse soon, and then the person doesn't get worse, they only seem to get better. So where is this all going?
So when I was in med school, when I first started in med school, I thought tests were like a light switch, on or off, yes or no. And that's the goal of a test, but they don't work that well. So some tests have a variability, and not every test is perfect. And so these are biomarkers which are trying to give insight into how the person is doing, but they're not 100%. And so we're not going to, I hope, make unilateral decisions based on one metric. If you have, for example, an MRI that shows a bunch of new spots, an octave test, which is normal, I'm not okay. Even though the octave test said you were normal, I'm seeing spots on the MRI making me very, very concerned. That's an example. And so we have to take all of the pieces of information in aggregate to try to make the best clinical decision for someone. And one of the advantages to refining tests is to get them better and better and tighter in their ability to accurately describe what's going on.
Okay, thank you. Next, when will tolebrutinib be FDA approved?
So we don't know yet, but some good news. The manufacturer of tolebrutinib, a company called Sanofi, presented their case to the American FDA, and the FDA fast-tracked tolebrutinib, which means they agreed to expedite the approval process. So normally a drug can take a year plus to go through approval, but you can sometimes speed that up. So for example, during the COVID pandemic, the FDA fast-tracked the vaccines, and they were approved very, very quickly. And so in a similar fashion, the FDA has fast-tracked tolebrutinib for SPMS. And so I don't know when, but it'll be very soon. Also, when you look at the behavior of the manufacturer, presently the manufacturer has started to hire a sales force, which tells you they believe that it's going to happen sooner than later. Otherwise, they wouldn't start to employ a whole team of people to get ready to make it available to others.
Correct. All right, next. I just want to let everybody know that when Dr. Boster was talking about CAR T cellular therapy, I and my AV team were invited to Bristol Myers Squibb to speak with their top doctors that control their studies. And we did an interview, and compliance approved this just last week, their compliance, but they do not want this interview to air until towards the end of February. So you will be seeing this when it goes online. It's going to explain the procedure that much more. You'll see the questions that are being asked, and you won't get to ask any questions though. Sorry about that. All right, next person writes, is dalfampridine the same as effective as Ampyra?
So all drugs have multiple names to make it super confusing, all right? So dalfampridine is the generic chemical compound, and there is a brand called Ampyra. So that's like saying there's tissue paper and there's a brand called Kleenex. So you can buy Kleenex brand tissue paper, or you can buy a different brand of tissue paper. So presently there is branded Ampyra and there's generic dalfampridine. And generic dalfampridine can be made by different manufacturers, and some patients respond to the generic dalfampridine dandy like candy, and some patients don't. So what I have noticed with the almighty insurance situation that we have in the United States is that insurance doesn't want to approve Ampyra branded because of the price point. And so they want patients to first try the generic. And so we oftentimes will prescribe the generic. And if the patient responds, then they take that. And if they don't respond, then we'll explain that to the insurance company and say now they need to approve Ampyra. And it's almost always improved.
Okay, thank you. So that's basically the same as saying gluteramine acetate and Copaxone.
Yeah, so that's exactly right. Copaxone is a brand. Blutopa is a brand. They're both brands of gluteramine acetate.
Great, thank you. Next, person writes, is there any test we can get for our kids to rule out the disease for them?
No. The DA test that I was talking about is not used for diagnosis. Okay. The best test that we have to look for MS is an MRI of the brain and the spinal cord. And I do not recommend getting MRI scans on children just because their parents have MS. If a child or an adolescent whose parents have MS develops new neurological symptoms, I will work them up in my clinic and I will get an MRI on them to try to elucidate whether or not I think I have MS. Another test which can be helpful is a lumbar puncture, a spinal tap. And those are the two most useful tests in trying to clarify if someone has MS, independent of their age. Now, there are other tests that we can look at, like ocular coherence tomography, OCT, and things like that. But I think the two most useful biomarkers presently are the MRI of the brain and spinal cord, as well as a lumbar puncture, spinal tap.
Thank you. Why do some people with uveitis go on to develop MS?
So uveitis, itis means inflammation. So uveitis is inflammation of the front part of the eyeball. And if someone has uveitis, they have an increased risk of developing MS. We don't know why, but we know the observation that if you look at a population of people that have uveitis and look at a population of people that don't have uveitis, those that have had uveitis have a higher risk of going on to develop MS. It's also worth saying that if you have one autoimmune disease, you're more likely to have a second autoimmune disease. And uveitis is considered like an autoimmune process by some, at least by some.
Okay, thank you. With 10 minutes remaining, let's get on with things. All right. Should a person be concerned if their doctor only orders MRIs of the brain and not of the spine?
So MS affects the brain and the spine. And I think it's appropriate best practice when you're working someone up for MS, when you're diagnosing them, to get a brain, cervical, and thoracic spine MRI. I think we need all three as we start the process of monitoring. I think that the brain MRI is best ordered once a year. And I think that getting at least a cervical spine MRI every other year is a good idea. Now, the consortium of MS centers suggests only getting a cervical spine MRI when patients have new symptoms attributable to the spine. But in my practice, there can be silent cord lesions, although they're not very common. And so I think it's better to get a spine MRI. Now, when you really need to get a spinal MRI is when you have new neurological symptoms which relate to the spine. And that's when I think it's the most useful.
Thank you. Next, T cells, B cells. Can you tell people the difference quickly?
Yes. So B and T cells are part of the adaptive immune system, and they're both born in the bone marrow, and they're named based on where they grow up. So B cells are born in the bone marrow, and they stay and they mature in the bone marrow. So they're called B cells for bone marrow. T cells are born in the bone marrow, but then they leave and they go to school at T cell university in the thymus. So they mature in the thymus. So they're called T cells because they are mature in the thymus. So that's why they're named B cells and T cells.
Okay, I think one time you explained it as the T cell's the fighter, the B cells get T cells riled up, T cell attacks the brain and the spinal cord, and B cells enable T cells to work.
Yeah, what he said.
Thank you. You said that once. All right, next, Tysabri versus B cells or Tysabri versus BTK inhibitors. Why would one go off of Tysabri to try one of the others?
So Tysabri is one of the most effective drugs to treat multiple sclerosis. Been around since 2004. It's still probably in top 3 FDA-approved therapies to treat MS. It's one of the fastest onset of action, and it has a side effect of giving people energy, right? And not everybody responds to it. Not everybody tolerates it. And some people can develop a risk of PML, which makes them not comfortable staying on it. So the most common reason that someone comes off Tysabri is because their JC virus goes up and they're at risk of PML. And that's the number one reason we see people leave Tysabri. It's less common that Tysabri doesn't work or that it's not well tolerated. And so if you are no longer safe on Tysabri or you're not responding to Tysabri, just like any other drug, then you're going to look for other drugs to take. And that's the most common reason.
Thank you. So there are a lot of people out there that are fearing, they have pros and cons about AI, and a lot of them fear AI. They're concerned with AI in their healthcare with multiple sclerosis. They're leery and distrustful about these new things like anything else. I remember when they were leery and distrustful about a cell phone. But what can you tell them about AI to make them feel better?
So I think technology or advances in technology are scary, and they do have a risk. But a lot of times we are scared of something and then it becomes standard. And I think a cell phone is a good example. So our cell phones track us. Our cell phones listen to us. Our cell phones also can translate any language. Our cell phones can do advanced mathematics. Our cell phones can do video chatting with anyone in the universe. I mean, there's pros and cons to technology, but very, very, very few people, actually no one I know, refuses to use a cell phone. People in the United States used to get around on horseback. So if you wanted to go to another village to meet someone, you would take your horse, or you would take a carriage attached to a horse. And when cars came out, it increased death by magnitudes. So cars are not as safe as horses. But I don't have a single person in my life that goes to work on a horse. I don't know anyone that uses a horse for transportation. And these are all examples of the pros and cons of moving forward with technology. AI is not worked out yet. And I think the reason that a lot of people are scared is because it's a black box, because the computer algorithms are super, super complex. And what I can say is, at least in the medical field, any technology, whether it be a new therapy, a new drug, a new diagnostic test, is vetted not by like one guy, but it's vetted in clinical trials again and again and again, tested in different populations by different investigators. And we need to see that they're reliable. I'll give you a quick example. There was an AI used by an insurance company to screen for risk, and it by accident, provided less care to African Americans, right? Which is terrible. And it was clarified and it was removed and it was updated and fixed, right? So this is just an example about how AI is not yet perfect and how it's a works in process, but that was identified and that was fixed. And I think that's what we're going to see. Medicine can be described, medical education can be described as controlled mistakes. So the way that someone goes through medical training is by being allowed to make controlled mistakes under supervision. And so don't ever do that again. And I also think that the development of MS therapies, the development of testing, things like that is also done through careful measures. And I think AI is on the same journey.
Great, thank you. Next, before I get into the next question, person writes, I have to say this. Okay, person writes, best show in the world is to watch you and Dr. Boster. Thank you.
Thank you.
Thank you. All right, 3 minutes remaining. We've got, would you put patient, I'm bringing this up because this one really needs to be taught how MS works. Would you put MS patients who are older on a DMT like Briumvi, given that it weakens the immune system?
So I don't think it's appropriate to be ageist. I'll give you an example. I saw a wonderful woman today who was diagnosed with MS in 2023. And on 2024, she had a big enhancing lesion, had an MS attack. I forgot to mention that she's 69 years old, right? So it doesn't matter that she's 69 years old. She has active relapsing MS and absolutely needs treated. So I think that when you are considering a medicine, and Briumvi is a high efficacy B cell depleter, you have to consider all the factors, including risk of infection, and older age increases risk of infection. That doesn't mean that they're not allowed to have it. It's just one of the many, many factors that we have to consider when picking a drug for someone.
Okay, next, thank you. All right, next one writes, going back to your horses, there's an island, Mackinac Island in somewhere in Michigan that still uses horses to get around. Next one. Sorry. Next one. I hear of so many people with MS who still get UTIs a lot. Why is this?
So the urinary tract system is controlled by your spinal cord, and damage to the spinal cord from MS or damage to the brain from MS can interfere with the way the bladder works. And so it can create bladder spasms, it can create urinary retention, and it's a setup for urinary tract infections. And so a lot of times the damage to the brain or the spinal cord can result in dysfunction of the bladder and increased risk of urinary tract infections.
Okay, thank you. Next, how does someone with MS get assessed for what living arrangements someone is best suited for?
So there's a field in medicine called occupational therapy. And occupational therapists do a lot of things. They can do adaptations in the workplace. They can do driving evaluations for like needing hand controls or teaching you how to drive with one foot, for example. And they can do something called a home wellness evaluation or a home safety evaluation, where they literally come into the home environment and they can say, you need to remove that rug, you need to lower that railing, you need to put up a railing here, we need to change this, the height of this toilet, and they can help craft those kind of things. When someone is considering going into a nursing facility, for example, there are different stages of care, and some people need assisted living where they live on their own in an apartment, but a nurse comes and helps them fill their medicines. Other people need to be in an environment where someone feeds them, right? And so these are assessments that are oftentimes done by occupational therapists.
Okay, great. Last question, and something that you brought up recently. How does insurance hurt MS?
So I have a YouTube video that talks about this exact topic, and it's a heated topic. I'll simply say that one of the things that's really, really frustrating as an MS neurologist is that when I make a shared medical decision with a patient that we've identified the most appropriate drug to treat them in that moment, we then submit it to the insurance to see if they'll pay for it. And sometimes there's a denial, and they require a prior authorization. They can deny that prior authorization, and then we do battle. And that creates delays in care. And there was a recent study that proved that prior authorizations and delays in care results in more attacks and more damage. So you can check that out on my YouTube channel. But denying a patient something that they need can create a problem where they have more attacks and they don't recover. And so it's a very frustrating system to work in.
Thank you very much for that answer. I want to say thank you to Dr. Boster. I want to say thank you to the 70 plus people online that we've had online tonight. And I want to say adieu. Have a great night. Be well.
Thank you, everyone.